Major funding for these programs is made possible by grants from Chase Commercial Term Lending and Capital One Bank, New York Community Bank, the Witkoff Group, M&T Bank, Perfect Building Maintenance, Genova Burns, Jean Tomasi and Webster, Greenberg Traurig, Kilroy Architectural Windows, New York's Window Company. Additional funding is provided by grants from AKA Hotels, Corman Communities, Aerial Property Advisors, Bank of America Merrill Lynch, Bank Leumi USA, Briarwood Organization, CBRE, Colliers International NYC, CPEX Real Estate Services, Cushman & Wakefield, Customers Bank, DDG, Dime Savings Bank of Williamsburg, Douglaston Development, Levine Builders, First Nationwide Title Agency, Flushing Bank, Friedman, Gemini Real Estate Advisors, Hap Investment Developers, Herrick Feinstein, Investors Bank, James D. Kuhn Real Estate Institute at Syracuse University, James Orphanides, Chairman USRealty.com, John Katsimides, Red Apple Group, Margolin Weiner and Evans, Madison Realty Capital, Massey Knackle Realty Services, Matone Group, Meridian Capital Group, Newmark Grubb Knight Frank, New Banks, People's United Bank, SJP Properties, Sterling & Sterling, Stonehenge Partners, TD Bank, Terra CRG, the CUNY TV Foundation, the Continuum Company, Urban American, and these friends.
Who understands healthcare? I mean, there's nothing, I don't know, there's an exchange, there's an Obamacare, there were HMOs, there are all these terms, I don't know. Can I go for an x-ray? Can I get a mammography? Can I go see a doctor? I have no idea, and neither do my guests, I don't know. Fortunately, I brought together today 4 individuals who are going to try to explain the maze of healthcare for both the consumer and for the companies. My guests, they include Rick Lira, who is the founder and chairman of the Cambridge organization. Drew Franklin, who's director of business strategy for ENT Analogy Associates. Alex Gradisa, who is the managing partner, co-founder, and CFO of Dinsmore Steel. And last but not least, a doctor. Okay, my friend Dr. Richard Bernstein, who is a clinical associate professor at the Icahn School of Medicine at Mount Sinai, also a consultant to Oscar, one of the insurance companies. So you and I go back so many years when, there were indemnity, where people would get their first dollar of insurance, where doctors were running practices. How do people understand what's going on today in healthcare?
Well, like in the past, there's always this paternalistic element.
Is there the dummy guide for healthcare? I mean,
not yet. There's always a paternalistic party involved, whether it's the employer's HR department or some other benefits consultant that's basically limiting the range of choices. But now you have the exchanges where there's a set of...
Would you explain what an exchange is? I mean, people don't understand this.
Yeah. It's basically a website. Yeah, it's a website where you have options to purchase insurance.
Doctor, isn't it like Amazon, where if you want to go on and buy a product, you can choose?
Yeah.
I didn't realize we're at Amazon. Okay, and I can buy different prices, and I look at which vendor is selling it to me.
Yeah.
Basically, that's what an exchange is.
Yeah.
I didn't mean to interrupt.
Yeah. So it's a website where you have those choices.
Anyway.
No, you have a choice of various levels of cost sharing and benefit design. So it's what's nice is that there's a certain defined set of what are called 10 essential health benefits. It's true of all these exchanges.
So would you tell me what these 10
essential? Well, every state defines what
Let's take New York and New
specifically,
Jersey.
but within these, there are 10 categories. There's hospital care, there's mental health and substance abuse care, there's pediatrics, including now dental and eye care. There's, of course, office-based care. And so the kind of spectrum of things you would expect to be covered. Each in one of these 10 categories.
Is that only what's covered for under Obamacare, or is that covered today by all insurance plans?
All insurance plans must include those essential benefits, preventative care and everything that
Right.
Rich
But
mentioned.
what about the costs? What about the costs and what about the deductibles? You know, what are those?
Well, at least in the context of the exchanges, there are five different levels. There's 4 metals, they're called, that define how much or how little they pay for benefits and how much cost sharing there is. So you have platinum, silver, gold, and so on. So there are 4 levels of exchange, and then you have what's called the sort of catastrophic coverage for people under 30 who are basically young, healthy, so-called invincibles. And they have a really high
Masters of the universe
deductible,
coverage?
yeah, high deductible, very low cost, geared to that particular group.
So you, I mean, ENT Analogy Associates is the preeminent ENT specialty group around with over 160 doctors, many offices around the tri-state metropolitan area. How do you, as a company, you know, a group of 160 doctors, look at the different exchange programs, and how do you make a determination which hospital you want to be involved with and so on?
Well, let me just say, you know, unfortunately, there's no kayak of purchasing healthcare. So the consumers, number one, who are coming to our practice are really uncertain of some of the things that they've signed up for and what it includes across those 10 categories. But for us, in terms of being able to decide which plans to take, it requires a certain number of membership, covered lives in the plan so that we know it's a sustainable business model, as in the Oscar plan. And then we also look at the reimbursement across certain services to see that are those rates commensurate with what we're getting in the marketplace and to provide our services.
How do you see, you know, I want you to introduce Alex because he has a very interesting concept.
He does, Michael, thank you. As a broker, we go to employers from 2 employees up to thousands and present them with the various plans that are out there. The availability of choice now has become very important, that many employers want a choice of health plans. They want someone to have the payroll, and they want someone to administer when an employee enrolls, when someone's going on COBRA. So they're really taking technology today and turning that into a more efficient HR department. We work with Alex, who represents hundreds of PEOs, which are...
Now, a PEO is?
A PEO is a professional employer organization. Essentially what it does, it's a single solution provider that takes groups anywhere from 5 employees to 500 and pulls them into a larger group of a couple
in
hundred
essence,
thousand.
you know, you're giving the economy of scale.
That's correct.
I mean, as a good example, and Drew knew the company that I'm involved with, a number of years ago, I remember they were, you know, they had 25 employees. They had a young group, you know, basically most of them were really under 40, you know, but many of them, wives, you know, were planning to have children, and their premiums went up substantially. I mean, like it was a 40–50% increase because they were community rated into a small group. And the old man, or the sage, let's say, said, I think there's something called this PEO, or the opportunity, and subsequently they were able to buy different coverages for different classifications of employees, providing the same coverage and saving them initially some money.
You know, I think, though, just for people who were intrigued by the idea of Obamacare and what is the maze, that what we're talking about is actually outside of Obamacare per se. Obamacare was you know, had 3 primary purposes. It was to address the uninsured and to make insurance affordable, as the name implies, but also to improve quality and do something with the unsustainable cost trend. So it had three principal goals. Now, in addition, it added some nice little features to Medicare and to Medicaid, and affected the employers and what they can and can't do, and their taxes. But the core of what is Obamacare, its principal things, were really to target the huge, the millions of people that were uninsured in this country.
But let's talk about another category. Let's talk about someone. Okay, I know under the changes under Obamacare, children up to 25 years of age are covered. It used to be up to
26.
Up to 26. It used to be 21. So now you have a situation of somebody who recently graduated college and perhaps has not found a job, and they're over 26. Let's say they're over 26. They need to find the coverage. And I remember this was a problem. I would call Rick up or I'd call a friend. I'd say, I have somebody who needs this type of coverage. And they'd say, you have to go in, unfortunately, to, let's say, an Emblem one single program or something which a lot of doctors wouldn't accept. You know, it didn't have the best benefits. You'd find the hospital in Dubuque, Iowa, who would accept the patient over here. So you had a circumstance. Now under Obamacare, it sounds like that college student or somebody who's finished their master's or something later on has an opportunity, not because as the concept of the uninsured who've had no insurance, but the concept of providing some additional coverage for them.
Well, he was uninsured technically at 26.
No, I agree. But as opposed to someone who was financially in a different case.
Well, in the state of New York, you could be on as is dependent on your family's medical plan through the age of 29. So that's specific to the state of New York. And what we've been seeing is a lot of these younger individuals that are not being covered under their family's plan essentially have access through the exchanges to subsidize medical care and plans. So that tends to be a very good option for them.
Certain people aren't aware, there have been these new exchanges like Oscar, and you were saying, but the other exchange?
Health Republic.
Health Republic. But in addition, the hospital system, the LIJ North Shore Healthcare System, set up their own insurance exchange where they put all their doctors and all of their 16 hospitals and their nursing homes and everything into that system. Do you see this as perhaps something that may be happening, with the evolution of healthcare in the future?
Yes, definitely, yeah.
New York is a very fragmented market. There are a number of health systems. There are a number of prerequisites that you have to have that LIJ saw. They had the entry level to care at the primary care physician level. And then downstream to specialists and subspecialists, they realized that they can have their employees access care, and they controlled all of the pieces along the way.
But insurance, the biggest problem that everyone has had with insurance is that the premiums are going up. Every employer says, my premiums are going up. I mean, the cost of coverage.
You're right. It's very difficult. With the advent of the ACA, the Affordable Health Care Act, companies had to add all of the preventative, the 10 keys that the doctor mentioned. Now, on top of that, so each year, the medical insurance would trend up 8, 10, 12%. Now there's an additional 3.8% tax before the trending. So an employer with 40 people, we were with a client today, they're paying $2,500 a month per family for coverage.
So they're paying $2,500 per month per family. That's $30,000 a year. And then there are deductibles, right?
There's an in-network deductible, it could be $1,000, a family deductible of $8,000, and for the employers, everyone's saying, the papers are saying, well, prices are coming down. Not for the employers. That's why we use a PEO in many cases, where you can consolidate that you have the economy of scale, as you said before.
Now the big question also is, many people, because it's difficult to get to see a primary care physician, or if there's an emergency, they've been running to emergency rooms. Now, we have had consolidations of hospitals. We've lost a number of hospitals, especially in New York City over the years, and people, the average stay at an emergency room, the average amount of time you have to wait is probably 6 hours, unless it's a trauma that something's over there. How do these coverages take into consideration today urgent care centers, which is a big trend that there's venture capital.
Retail clinics too.
No, retail medicines. See, when you and I remember retail clinics, I call them Medicaid centers because
Doc in the box.
the doc in the box that really didn't care about it. Today, I believe the urgent care center for the better organizations, because there's always going to be some good and some bad, are really looking to. They provide a major service.
Yep.
Michael, we did a study for one of our clients with over 2,000 employees. The average cost of an ER visit came just under $3,000. When they took the average cost for CityMD as an example, it was something like under $400. So what we help our clients educate their employees and say, look, if you've got a cut, if you have a burn from a stove, go to the doc in the box. But hear me out for a minute. So when the claims experience comes back to that employer and they see $450,000 of ER visits versus 20 times the visits for an emergency, for a clinic. If you can educate your population, your claims are going to come down, your renewals will be less.
Right, but if the person has a deductible, I mean, if somebody has a couple of $1,000 deductible and they go to the emergency room and it's not covered, that deductible is going to be used up. If they would go to the urgent care center, who's affiliated, who has a relationship with an ENT or with something over there, their out-of-pocket is going to be less.
Well, the way you develop a plan is you have a copay for the emergency center versus the urgent care. So there may be a $500 copay for the ER, but a $50 copay for the urgent. So you're incentivizing your employees to use that when necessary.
So this is called financial steerage. So it's sort of education through the pocketbook, whereas people become educated as to what their benefits are and are aware that, sure, I have a headache, I'm worried it may be a brain tumor, but really, maybe there's just someone I could talk to reassure me for $50.
But aren't there also services today where you can call up? I remember there's
Teledoc.
Teledoc.
Right, the Teledoc.
Yep.
Okay, so what's the Teledoc, and how do you?
Now, Oscar uses them. And it's a guaranteed response time within like 20 minutes of a call with a board-certified doctor. I've read the dialogue between patient and physician. And what's interesting is that virtually 90% of the calls are things that could have been an ER visit or an urgent care visit, but now is a phone call with advice for much less. So it's what's called demand management. It's a way to even further reduce the inappropriate use of emergency rooms and even inappropriate use of a
One could argue
facility.
that telemedicine has its benefits, but in reality, it's not for everything. There are conditions, even dermatologic, otolaryngology, where calling someone even with on an iPhone is not going to be able to allow you to take care.
There's a great book called Give and Take by one of the youngest full tenured professors at Wharton, Adam Grant, and he talks about a study that was done, perhaps at Wharton, where they analyzed radiologists who looked at X-rays and CAT scans from a distance, and the other ones who looked at the CAT scans and also looked at a picture of the patients, and it was they treated them better if they saw the patient. Okay, this is a statistical, because if you don't see the patient, you're looking at something, and I think even though the Teledoc, as you bring out, you can do it on an iPhone, you can do it on a Skyping,
right.
but it's not actually seeing there.
Well, there's a certain level, the scripts that are designed by companies that do this form of telemedicine are fairly sensitive to the potential liabilities. And for example, they will never prescribe any psychotropic medicine, any medicine for a anxiety or psychotic disorder, anything like that. They will just say, I'm sorry, we're not allowed to do that. And in addition, they will ask the person, I was just looking at one the other day, they'll say, well, person had symptoms of sinusitis. They said, well, bend over and tell me what's happening to the pain in your head. Well, it got a lot worse, and that's a fairly typical symptom of sinusitis. So they did an initial management with some nose drops and said, and if you're not better, then go to your doctor or go to an ENT doctor. So there's sort of a triaging, an interaction that can become fairly sophisticated, reduce the risk, reduce the cost, and occasionally, of course,
Let's go back to the original question for a second, which was, are there ways to lower cost by steering patients to an urgent care center, a city MD, instead of the emergency room? So you're basically matching the patient with the lowest cost of care, and I believe that these urgent care centers are a pathway, and they do filter down to the subspecialties when there's a need. The entry point of telemedicine will be good for certain things. It may send them to see to a physician in person, and they may end up sending them to a specialist. I just think that there's a very limited scope, in my opinion, of the telemedicine because of the points that you made.
But I'm hearing, I'm hearing all these things. I'm hearing deductibles. I'm hearing gold, silver, platinum, metal, other things. I'm hearing different types of coverages. I'm hearing, HSA, health service, But it's a maze. I mean, how many companies do you deal with?
Well, through the PEO, our private exchange network, we have access to a universe of about 700 PEOs out of 1,000 plus that are across the United States. So in dealing with carriers, professional employer organizations usually will have a master carrier of, generally a national, Aetna, Cigna, Blue Cross, and so forth.
So the choices, sometimes, it's like going, as one would say, the old days of Chinese restaurant.
Right.
Give me column A and column B. They don't have
Right.
it anymore. Okay, the too many columns are dangerous. People know that people remember. Blue Cross was always an entity, or GHI in the marketplace. Aetna, Oxford, Cigna, the name plans, and then there are these new companies, right?
Without a doubt, the Oscars and the Health Republics. But, your point is well taken. I don't know if you saw the bit that Jimmy Kimmel did where he asked people on the street, which do you prefer, the ACA or Obamacare? And it's a riot, to see this. And 8 out of the 10 people said they definitely prefer the ACA, and they gave their reasons. And the complexity that's out there for the consumer, for the employer, is vast, and there's everyone gives a different take on it, and it's very complex, it's very confusing, and it's going to take years to settle down, in our opinion.
So do you see, and this relates, do you see more people today going to the PEOs? I mean, as I explained before about my company, which had a number of young people, it really saved them money. They didn't really look at the other benefits, the workers' compensation or the unemployment insurance or the group buying situation. They looked at a specific need. Okay, I got health insurance and I want to cut my costs and I want to reduce the opportunities.
Yeah, we see a lot of companies evaluating PEO as an option and a way to get access to health care. And, PEO is not a new concept. It's been around for years. It's being more and more looked at because of everything that's going on with Obamacare. So more specifically here in the New York marketplace, as you had mentioned before with community rating, groups under 50 are essentially put into a pool, and that's based on zip code. So a demographic of all 21-year-old healthy males is getting the same rates for that same plan as a group of all 85-year-olds. So what PEO essentially allows, a company to do is get access to health care that's underwritten specifically to that group of 21-year-olds, given rates that's more cost advantageous.
Here's a question that certain people always, my company, they were able to give different coverages based on different employee groups. How's that happen? I thought we don't have discrimination.
It's really not by the group, it's by choice now, so that everyone's got a different fingerprint. So you may have X amount of singles, X amount of families. Someone may want to stay in a specific network and go with a lower plan than the higher plan. Under one umbrella, you give the consumer the ability to choose. One thing about the PEO, there's been a misconception with business owners about PEOs. It's a co-employment agreement. The PEO cannot fire or hire
They're
an
an
employee.
administrative service.
They're an
That's exactly
But the
what-
business community is confused about it, and they feel threatened when, you know, when you say PEO, and it's an educational process.
How do you determine, you know, which insurance groups you want to deal with? How do you look at that? Because you're a large group. You know, you're 160 docs.
Right. We are looking at a number of things, and we do look at the size of the plan, and we look at the reimbursement that they offer, you know, for their services. But I think the most important thing for us is to do some due diligence on that plan. Smaller plans offering higher allowables, higher rates, aren't always the best way to go because they, you know, we don't know their rules for a managed care referral. We don't know their rules for prior authorization. So what's on paper is not always the case. We're also doing a deep dive into a financial analysis of them to better understand, you know, if you look at their risk pool, can they afford to pay us what they say they're going to pay us? And so larger plans like the Blues and the Aetnas and the Cignas are easy because they're large multi-state plans. But when it comes to some of the smaller plans, it's a little bit more challenging because the information is not as accessible, and we take a little bit of a harder look, and sometimes we get spooked by it.
Rick, HSA. Explain what the HSA is.
HSA is an acronym for Health Savings Account. So what a company will do, will put in a high deductible, and let's say it's $4,000. And the company will lower a premium by, let's say, 50%. The company will issue, through a third party, a credit card so that if I have to go to the doctor and pay that deductible, I can swipe my card. When you look at the demographics of a group, very rarely does 100% of the group use all of that deductible and co-insurance. So that can stay in an individual's account.
And that's what happens, you know, normally at the end of the year when you pass any of the eye stores, they say, use your HSA up before the end of the year because it's a
No,
December.
that's an FSA.
Right.
That's an
a
FSA.
flexible savings account.
But the HSA now, that you are allowed to roll over unused dollars, and if someone
So
retired,
HSAs you can roll over now?
Yes.
FSA is
like
use
a
it or lose
401.
it. Use
Right,
it or lose it.
FSA is.
FSA is the problem, the flexible spending account.
It's essentially like a 401k for your health insurance, and it really
FSA is, yeah.
You know, are people going to feel comfortable understanding the ACA, Obamacare? Is it a learning curve? Because, I mean, when you were involved with the initial times of HMOs, okay, HMOs just don't exist anymore to speak of, you know, to the level. Do we see Obamacare continuing, people complaining, or?
They'll continue to complain because that's the nature of, because it's never ideal. But the big picture, Mike, that we haven't fully addressed except indirectly is that the costs are going up for everybody, the employers and being passed down to the employees. But at a national level, the rate of increase is pushing out other national priorities, whether it's education and infrastructure. So push is coming to shove here, and we need strategies to reduce the rate of increase. And one of the features of Obamacare are ways to reduce those cost trends.
27 and a half minutes is definitely not the appropriate time for this. And hopefully in a couple of weeks or in a couple of months we'll come back and we'll explain this healthcare maze. But I think we've got some good basic idea. I'd like to thank Rick,
thank you.
Drew, Alex,
Thank you.
and Dr. B. See you next week.